Yeah, great to be here today. I will talk about radiology automation and how AI can help to make healthcare much better. And I will focus on some of the opportunities, but also challenges of this. It's actually great to be here on stage because I co-founded Hack Zurich and then Digital Festival 6 and 4 years ago when I was still a PhD student at ETH working on machine learning research. So it's great to talk about some of the work I've been up to since then. I started Merantix, a venture studio on machine learning 3 years ago in Berlin. What we do is we basically incubate, first ideate, and then later scale AI companies to really turn research into product companies. We do so by having a common technology platform, and right now we have actually 3 companies active. So we have one company in the automotive space working with some of the large car manufacturers on autonomous driving and providing an infrastructure there. And then secondly, there is a healthcare company, which I will talk about today, which focuses on automating and improving mammography screening. And then we have a solutions provider, which is looking into some new industries. And there are lots of new things we will start. We will probably incubate 2 new companies starting next year. And these are just some industries we are looking into at this point. Now, let's talk about radiology. So the problem we're facing is actually a problem to 41 million patients every year. So every single year, 41 million people die because they had a curable disease which wasn't detected early enough. And so we at Merantix Healthcare are a big believer in using screening on a regular basis to basically detect these curable diseases as early as possible. Now, when you think about AI, AI has clearly huge potential, especially when focusing on radiological or medical imaging data, where lots of research has shown that AI is basically as good or even better than a human at understanding those medical images. So there was some work from DeepMind which focused on eye diseases and could basically from a single read detect up to 50 or even more eye diseases. There was some work from Stanford researchers focusing on skin cancer. And then there's the work we've been doing at Merantix, which is basically helping people in the mammography space doing better work. Now, even though the technology is there, adoption in healthcare is actually pretty slow. So if we look at this McKinsey report from 2018, which is about AI adoption in several industries, automotive and high tech is leading there. You can then look at retail media, and then actually healthcare is at the bottom. And that is a really big problem, and so we believe there are some challenges why this is the case, but there are also some tricks to basically overcome them. And that's basically what I want to focus on in this talk today, to talk about some of the learnings we've made in the last 2 to 3 years and bringing AI into the healthcare system. Now, let's focus on medical imaging. Let's focus on mammography screening. So when we started, we actually just sat next to a lot of doctors and just saw how they work. And so I want to share some photos. So this is a typical mammography workflow at some of our partners. So you can see some paperwork printed out. Then there's some software to look at the medical images. And then there's another very beautiful software which helps you to do the reporting. And so you can see it's a very broken workflow. It's different software solutions. Some look like they were built in 1992. There's paper, and it's just a very broken workflow. And so if you think about the first generation of machine learning in medical imaging, it very much focused on CAD systems, so computer-aided diagnostic systems, which basically help the doctor in finding the critical regions in the image. So how it works, it would basically highlight in the image the regions where the doctor should look at, and then that would maybe support the doctor in doing a better job. The problem is that most of these solutions actually have very, very bad adoption, and for several reasons. So first of all, the workflow is still broken. You're still dealing with several pieces of software. Secondly, even though it highlights the doctor's interesting regions, it actually creates more work for the doctor because instead of quickly looking themselves at the image, they now also have maybe 20, 30 false positives in the image. They have to now evaluate and then either click away or agree to. And another problem is that sometimes even the joint performance of the doctor in these decision support systems actually is worse than just the doctor, because the doctor is getting biased into the wrong direction and then only starts looking into the regions where something was highlighted and maybe oversees some of the more critical regions. And so this is clearly a broken workflow, and we don't believe that the classical computer-aided diagnostics approach is going to get widespread adoption. Now let's look at the real problem. If you look at from a statistical point, we are talking about screening cases, so cases where mostly healthy patients are checked on a regular basis to see if they have a certain type of cancer. And so in the case of mammography, 97% of the patients are actually healthy. And so then if you look at this little dot there in the middle and zoom in there, around 3% of the cases are referred, so could be suspicious, and then only 0.7% of the cases are cancer. So, and then there is another part, which is the critical part, that even though only a small fraction of population at the moment is exposed to screening across several modalities, still 20 to 30% of the cancers are missed. So it's highly broken. And I think if you think about this from a daily job perspective, some of these doctors are looking at hundreds of cases every single day and to basically try to find a needle in the haystack. And it's very difficult because it can be very boring when you look at 100 images and less than one has actually cancer. So you have to look through all these normal images. Your bias, your prior when going into a new study will be always, oh, it's likely not cancer. But at the same time, you can't miss something because it's about life and death. And so there's a big problem in kind of boredom, looking through all the normal cases, and also this bias of usually thinking that the next image is going to be normal. And so that's why we've actually said, okay, instead of focusing on the cancerous cases, so all the cases where basically most of the computer-aided diagnostics solutions focus on, let's focus on the 97% and let's make that better because that will have a much larger impact. And so what we've built out is a system which basically tries to rule out as many normals as possible. So the way it works is that we basically at the moment can automatically diagnose around 40% of the cases, and that means we write a full medical report towards the end, which just needs to be submitted. And then the remaining 60% we actually forward to the doctors so they can do their normal radiological workflow. And that has a few advantages. So first of all, we actually truly automate. When we always talk about AI, but AI has to do a lot with automation. And here we actually automate 40% of the work. So we really have an impact in terms of the doctors being more efficient and thereby having more time for the critical cases or being able to diagnose more patients. Another advantage is that the doctors still have their normal workflow. They still look at the images. They are not distracted by any algorithms. They just do their diagnosis. And we take basically the more boring, the normal cases, off their back basically, so they can really focus on the more important ones. And lastly, we actually improve the sensitivity of the doctor because the problem the doctor is trying to solve is finding a needle in the haystack. And so if you basically reduce this haystack, what we do, the doctor, it's easier to find that needle. And so there's some studies which actually suggest that sensitivity goes up, and which we can also confirm with some of the work we've done in this space. Now, building that system, we had to acquire a lot of data, so we have been building 20 data partnerships with institutions around Europe, acquired a data set of over 2 million studies. These data sets are sometimes longitudinal, so have the same patient coming in several times, working with medical reports, biopsies. So it's quite a complex data set you need to really train the system, and we could probably talk another hour about some of the technical considerations when you go 1 or 2 levels deeper. But also there's all this data acquisition efforts, and that is, obviously you need to anonymize the data properly, so there's everything to make sure to be GDPR compliant. But then there's also and that was a surprise to us, there's also the kind of very practical problem of actually bringing the data from your partners to your cloud or your infrastructure. And so, when you want to upload a few hundred terabytes of data from medical institutions, it can take days or weeks or sometimes months. And so what we ended up doing is we had people driving by train or by plane with like huge racks of hard drives to actually copy the data and then bring it back to the cloud system. So that was actually probably one of the hardest things we had to realize when building this large data set to build this solution. Let's also talk a bit about like how this whole product looks like. So a lot of the companies who have been early in this space have very much focused on building algorithms and then trying to integrate them with third-party solutions. So what you saw earlier, basically you build an algorithm and then you put that into a medical viewer product. We don't think this is very good for several reasons. So first of all, I mean, we saw the broken workflow, so the workflow will still be broken. But we also believe that when you have the algorithm, if you have an algorithm which can automate something in this space, you want to not only integrate that into an existing workflow, but you want to redesign the entire workflow. So you actually improve something, and then basically get more users and also collect the data to further improve the system. Because we basically, build the whole system, we collect a lot of data on how the radiologists work, how they interact with the software, how much time they spend on what, and that helps us tremendously to actually further improve the solution. And then also, builds the infamous data flywheel. And so that's our solution. So it's an end-to-end workflow solution. There's a work list screen which basically focuses on showing the doctor what to work on, and also rules out the normal. So only the small section on the left, basically this highlighted circle, is the only part which is AI in this whole thing, because it basically highlights all the normal cases which are automatically diagnosed. Then there's a viewing product which is all around basically looking at the images, and then there's a reporting screen. And so you can see, and that was also an interesting thing to us, because we're definitely an AI-first company, but giving this solution to our doctors, even without any AI, they would already be around 50% faster than before, because the workflow solution itself already improved their workflow. And so you can see with now 40% automation and then more, we can tremendously automate this whole workflow and also make the overall quality much better. Now, machine learning scientists are very rare, and that's truly something you need to build a great solution here, because even though machine learning is getting more and more commoditized, when you want to build a robust medical product, which really also then gets certified and in the end is in a setting where it's about life and death, you need to make sure you have really the best talents in that space. And so we're spending actually a lot of time attracting the best machine learning research. We host paper discussion groups at the company every week. Everybody has to go to one large machine learning conference once a year. We host a lot of meetups. We do hackathons internally. So there's a lot of stuff we do to basically really build this machine learning ecosystem within Merantix, not just the healthcare company, to make sure the best researchers join us. And so we have a pretty good team at Merantix Healthcare, and I think that will also help us to further iterate the product. The other thing we do is, so as of last week, we were certified as a medical product. So now we're not just running in test settings, but actually also in clinical production. We spend a lot of time with governments and also the regulators, also helping them to understand what AI can do and kind of take the fear and talk more about the opportunities, and also help basically put the regulatory framework in the right context so that it is compliant with AI, because a lot of the regulatory environment was written in a time pre-AI, and so there's obviously some challenges in making this happen. And so we spend time with politicians, we build partnerships, and so now we have a certified product, which is great. Now, yeah, so far we've read 50,000 cases with this solution. 40% is automated, and right now around 30 radiologists are using the software, and our plan is to scale this to up to 1,000 radiologists until the end of next year. So there's a lot of distribution work to do at this point. And today we talked about breast cancer, which 1 in 8 women actually will get over their lifetime, and where early screening can help tremendously if done well. Secondly, we will look at likely lung cancer next year, where again 1 in 5 heavy smokers gets lung cancer at some point in their life. And lastly, you can also do a few things with eye diseases. And so we believe that machine learning can help to not only automate and improve the quality, but potentially also redefine some of the screening programs. So for example, that you could not have everybody come in on a regular schedule, but also personalize the screening procedure so that people get screened as often as they need to. So this is the healthcare team. They've done all the work, they've done a great job, and I think they will do a tremendous job in the future. And with this, I'd like to conclude my talk. Unfortunately, I can't be around for Q&A later because I have to go over to Hack Zurich, but please shoot me an email if you have any questions, and thank you for your attention.